The broadcast is now starting. All attendees are in listen-only mode.
All right, John, it's all yours.
Okay. Hello, everyone. This is John Ebersole. This afternoon or this evening, whichever time it is, I'm going to talk about MEG and EEG source localization and how we use it to localize epileptic foci in patients with seizure disorders. Now, finding these epileptic foci is certainly the critical and rate-limiting step in our evaluation of patients with uncontrolled epilepsy. There are a variety of techniques that we use to try to find these foci non-invasively. There are structural, like MRI. They're functional, like PET, SPECT, fMRI, MEG, and EEG. However, only EEG and MEG are direct measures of epileptic pathophysiology rather than indirect. Only these techniques are performed in real time, and only these techniques provide temporal sequencing of activity to characterize propagation. All the other functional imaging techniques do not have the temporal resolution to do this. Now, EEG is usually recorded simultaneously with MEG in most MEG centers, and it's commonly used to help find epileptic spikes. However, EEG is usually not subjected to the same source modeling techniques in most clinical centers. That's not the case, however. At Overlook, we model both. And part of this talk will be to show you why this is very important. Now, in order to talk about source modeling, I need to go back and review some basic biophysics of EEG and MEG. Now, this is about as basic as you can get. Here's some schematics of the pyramidal cells in our cortex. Remember that EEG is a result of extracellular potentials due to graded activity, EPSP and IPSPs. You can see here on the left side an active sink. Positive ions rush in, leaving a relative negativity extracellularly. A passive source down here, the other side, showing positivity. This separation of charge, negative and positive, is similar to a dipole and produces the EEG fields that we measure from the scalp. Now, one of the important things to remember is the relationship between the orientation of the cortex generating, in this case, the spike, and the field that it produces. If we look at simple source number 2 on the convexity cortex, here's the orientation of our pyramidal cells. They are orthogonal to the skull and scalp. And epileptic activity is usually surface negative. So we have a negative field here superficially, the corresponding positive field deep, and the field that we see on the scalp shows a negative field maximum here in hatched colors directly above the source. This is a radial field that is coming directly out of the head. This is the simplest possible source configuration, and in this sort of configuration, indeed, the source is directly under the maximum negativity. Source 3 is a little more complex because it involves a sulcus, and when you have two sides of the sulcus active at the same time, their field cancels out, leaving the bottom of the sulcus to predominate, producing another radial field. If all EEG were this simple, it would be very easy to localize things, but that's not the case because you have cortex that is not orthogonal but may be parallel to the skull or scalp, such as here in the interhemispheric fissure. This is the orientation of the pyramidal cells. Note that negativity is actually projected to the opposite hemisphere, positivity to the ipsilateral hemisphere, and directly above the source, we really have no field. It's a zero isopotential line. So in this case, it can be very confusing. It can be even falsely lateralizing the field. If we take perhaps a more relevant source, like at the base of the temporal lobe here, pyramidal cells are again located vertically in orientation. Notice with this base of the temporal lobe, all of the 1020 electrodes here in the top half of the head only see the positive side of the field. All the negativity is in the subtemporal region, showing why subtemporal electrodes are very important. But this is a tangential field. It is parallel to the surface of the skull, not orthogonal to it, and the source is under neither maxima but between the two. Let me go back. Here you can see a simple left temporal spike. And notice that over a period of time here between these cursors, the voltage field changes significantly. Here the negative maxima is basally, positive maxima is superior. Draw a line between the two maxima. We have a vertical orientation. 30 milliseconds later, an oblique. 30 milliseconds after that, a horizontal. This changing field orientation is due to propagation of the activity, and that will be important in trying to determine the origin of the spike foci. Now, MEG is different. If we go back to Physics 101, you may remember that whenever a current passes through a conductor like this telephone wire, a magnetic field is generated around it by the right-hand rule. That is to say, point your thumb in the direction of the current flow, and the magnetic field wraps around the conductor like the fingers of your right hand. That's true of a telephone wire. It's also true of a neuron. Now, unlike EEG, which is due to extracellular potentials, the MEG is actually generated by the current flow within the neuron themselves. In this case, from dendrite down to the cellular soma. If you put a bunch of these cells together in a palisaded fashion like the cortex, their magnetic fields will add together, and then by the right-hand rule, thumb pointing to the right here, the magnetic field wraps around these cells such that it actually exits the skull, comes around, and comes back into the skull. In order for this to happen, these cells have to be parallel to the surface of the skull and scalp, not orthogonal. So here's what I'm saying. If the cells, let's take this as a group of cells, are somewhat parallel to the surface of the head, then the magnetic field can exit and come back into the skull. So you have two maxima in a magnetic field. You have an efflux maxima and an influx maxima. And the source is between the two maxima, not under either one. If, however, the neurons are orthogonal to the cell, to the skull or scalp, the magnetic field circles around and around within the head and really never exits. So MEG is insensitive to sources that are radial, but very sensitive to sources that are tangential. So these fields are then recorded by the MEG system itself, which has pickup coils and has a very sensitive device called a squid that can record these minute magnetic fields only if it's superconductive, so it has to be immersed in liquid helium. So let me just reiterate this important difference. Radial fields generated by pyramidal cells that are orthogonal to the skull. EEG is very sensitive to these fields. MEG is not. Tangential, the pyramidal cells are parallel to the skull, such as in a deep sulcus or fissure. MEG is most sensitive to this orientation. EEG is less sensitive. Now, MEG fields are exceedingly small. Here's a scale from 1 to 10 to the 15th power, and most epileptic spikes are in the order of about 100 to 1,000 femtoteslas. The actual noise, electrical noise, urban noise, can be thousands or even millions of times greater than that, including the Earth's steady-state field. So in order to record these small potentials, the MEG has to be measured in a shielded room that absorbs all the extraneous magnetic activity. Here's the views of typical MEG machines. This is the one on the right is the one that we have at Overlook. This is an Electro machine. This is another manufacturer's machine. Both are essentially these big dewars filled with liquid helium and a helmet full of sensors that actually pick up the signals. So the patients usually lie in the device similar to this in order to record their MEG. This is, you can see here the spatial differences between EEG. You can see the actual electrodes on the head and the MEG sensors. In our particular device, the electric device, we have 306 sensors as opposed to, say, 25 channels of EEG that we record. Now, what we want to do are what we call electromagnetic source imaging. That is to say, we want to take the structural information that we have in an MRI and combine it with the electrophysiological activity, both EEG and MEG, so we have functional imaging, combination of function and structure. Let's think about the sensitivities of these two techniques. Studies have shown that it takes greater than 10 square centimeters of active EEG, of cortex with active EEG, to produce a signal that we can recognize above this spontaneous activity. That's a fair amount of cortex. So the EEG tends to visualize convexity cortex, gyral, or big fissures, but not individual sulci, because if you need 10 square centimeters of active cortex, both sides of the sulcus are probably active, and therefore their fields will cancel. Theoretically, EEG is sensitive to all source orientations, but it's more sensitive to radial than it is to tangential. Now, here's an example of a simultaneous recording of intracranial activity and scalp activity. This is a reasonably nice EEG spike, but look how much cortex is necessary to produce this. Look at all these contacts that are simultaneously active. And here's a diagram of it. You can see nearly a whole half of the lateral temporal lobe here. It needs to be active in order to produce this reasonable source spike. So EEG sources are not tiny. EEG sources of spontaneously recorded spikes from the surface are actually quite large. So when you think of the cortex that can produce an EEG spike, we sort of eliminate all the various sulci in this Montreal brain picture. So we have convexity cortex that produces very nice radial fields. That is to say, the pyramidal cells are orthogonal to the skull. But also we have some tangential activity in big fissures, like this interhemispheric fissure producing a tangential field, or the superior temporal plane or the base of the cortex will produce the vertical tangential field, or even the temporal tip here, which also produces a tangential field. So EEG sees both radial and tangential activity. The advantages of EEG is it is sensitive to all source orientations, even though radial are more than tangential. Because of that, it can characterize propagation fully, because if the spike or seizure activity goes from a radial generating field to a tangential one or vice versa, it can see both. We can record EEG for a long time, days or weeks, so we can more likely record seizures. It's now part of the standard epilepsy evaluation, and in comparison to MEG, it's relatively inexpensive, about an order of magnitude less. Now let's think about MEG. MEG can be sensitive to much smaller sources, 4 to 6 square centimeters. Because it needs a tangential field, it visualizes large sulci, fissures, and tangential cortical planes, but not the convexity cortex that produces purely radial fields. MEG dipoles more accurately reflect the source location, and as I said before, it's sensitive principally to tangential sources. So the MEG brain, now all of a sudden we see the sulci and fissures, but notice that the MEG is sensitive to cortex that produces tangential fields. Again, we have interhemispheric fissure. We have one side of very deep sulci. We have deep fissures as long as just one side is active, and certain planes like the temporal tip or the base of the cortex, etc., they're oriented such that they also produce tangential fields. Notice that the crowns of these gyri are not a source that MEG can see. The advantages, the big advantages of MEG is it is not attenuated by the skull or scalp. Magnetic fields pass through the skull or scalp as though they were not there. That's the single most important advantage. In addition to that, the modern MEG systems have fantastic spatial sampling because they have 200 to 300 sensors. Imagine trying to put 300 electrodes on somebody's head. Because it's not attenuated by the skull or scalp, it has superior sensitivity, seeing smaller sources. It produces a more accurate source models because of this. And another feature is it has a superior frequency sensitivity in that it can record DC as well as very high frequency activity. Now, when you think of these two, MEG and EEG, you can see because of the physics that the fields of the two are going to be orthogonal on the head. EEG field orientation is the same as the generator pyramidal cells. MEG field orientation is orthogonal to the generator pyramidal cells. And because the MEG is not smeared by the skull and scalp, MEG field maxima are closer together than EEG field maxima. Let me give you an example of that. Here's a spike from benign Rolandic epilepsy. Here's the MEG spike. Here's the EEG spike. Here is the MEG field. Okay, we have an efflux maxima and influx maxima, the sources between the two maxima here. Here is the EEG field of the same spike. Notice that the orientation is orthogonal, and the maxima are much farther apart. Here's the dipole models of both being relatively similar. So on the surface of the head, the MEG fields and the EEG fields are usually orthogonal to one another. Now, you probably get the feeling, and you're absolutely correct by now, that the two, MEG and EEG, are very complementary. This is very important. Let's just look at the various strengths and how they sort out. MEG is certainly superior relative to the volume conductor effects in that it's not affected by the volume conductor, that is the skull and the scalp. MEG has superior spatial sampling, hundreds. EEG has superior temporal sampling, not on the short side, but on the long side, being able to record days or weeks. MEG is superior in source area. It can see smaller sources. EEG is superior for radial sources, MEG for tangential sources, and theoretically EEG for deep sources. So you can see wherever there is a weakness of one technique, that's the strength of the other. Put the two together, and you have a very complementary diagnostic system. Now, what we need to do is take these fields that we measure and somehow reconstruct in 3D where the sources would like to be. In order to do so, we need some sort of biophysical model. And the one most commonly used is the equivalent current dipole, also called the single or moving dipole model. Now, it's a very simple model because it's a point source. And I've already told you that sources of spikes and seizures are not points, but they're quite extended. So to that extent, it's not an ideal model. However, it's one that's commonly used. It's very simple to use, and if you know how to interpret it, it's easy to use. For this model, the electrical or magnetic field at any one moment in time is modeled by the best fitting single dipole. So here is an example where we're going to use EEG. For this example, the EEG field is over there on the right. The blue area is the area of negativity. In order to produce this relatively wide field, the point source model of it here, this dipole, has to be relatively deep to the cortex in order to produce this big field. The MEG field for this spike would be a lot closer together, and its source could be a lot closer to the surface and more realistic as far as the cortex. So one thing you'll see is EEG dipoles tend to be deep to the cortex in the white matter. Don't worry about that. MEG dipoles tend to be more superficial in the actual cortex. Here's an example. Here's a MEG spike. Here are the MEG fields. Here are the two maxima. Again, we have the efflux and the influx maxima. These are magnetometers. These two are gradiometers. We really don't need to go into that right now. Here's the magnetic field measured from the sensors. Here is the MEG dipole, and this is the cortex that's associated with this dipole. This is the putative source of this potential here in the mesial occipital region, an orientation of cortex that would produce a very nice tangential field seen by MEG. Here's an example of an EEG. Here's the EEG temporal spike. Here's the EEG field, negative subtemporally, positive on the other side of the head. Here you can see it in 3D. And here's the EEG dipole. Notice that it's deep to the cortex, sort of in the white matter, but its orientation points out radially to this cortex, which is probably the source. So this sort of dipole we would interpret as having a source in this lateral temporal cortex. Now, in these recordings that we make of simultaneous MEG and EEG, we usually find that epileptic sources contain both tangential and radial field components. MEG will reflect the activity of the cortex that produces the tangential fields. EEG reflects the activity of cortex that produces principally the radial fields. And here's an example of a spike, again recorded in both MEG and EEG. The EEG has principally a radial field with the negative maximum here, positive maximum other side of the head. Here's the EEG dipole. It's deep to the cortex, but the orientation is such that it points to the cortex. Here's the MEG field. We have the typical dipolar MEG, the source between the two maxima. Notice the MEG dipole is correct up depth-wise up here in the cortex, where the EEG dipole tends to be deep, but the two actually are pointing to the same general area of cortex as the likely source. Now, as I said, most patients have both MEG spikes and EEG spikes, but the source models, the dipole models of them, commonly differ somewhat, principally by orientation, radial versus tangential dominant, but also location. They can be just millimeters apart, we like that, or they can be centimeters apart, and then there's an ambiguity. And timing, one source model can lead or lag the other, and we're obviously interested in the earlier one, not a later one that may be the result of propagation. So let's look at 6 different scenarios that show the relationship between MEG and EEG, and when EEG adds something to the solution or not. Let's have the orientation of the source. Here is tangential for the MEG, tangential for the EEG. The two are synchronous, and the bottom line in this particular case, EEG doesn't add anything because MEG is more sensitive and more accurate for tangential sources. And here's an example. Here's an MEG and an EEG spike in this patient. The MEG dipole solution is appropriate in the temporal tip. The EEG is a little outside the brain in this case because this person previously had surgery and has a skull defect and a breach effect, one problem that EEG has if there is a hole in the skull. So both of these fields are tangential, but the MEG is clearly superior. So in this particular case, EEG doesn't add anything. Let's take a case where the MEG sees a tangential source, but the EEG doesn't see it at all. This can happen, and obviously in this case the EEG doesn't add anything. Here's an example. Here's simultaneous recording of EEG and MEG, And you really don't see any definite spikes down here, but notice we have here, 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 and here we have definite MEG spikes with a beautiful dipolar MEG field. If you look at the EEG at the same time, you see a very weak field. It is there because EEG can see all source orientations, but it is not above the ongoing background noise level. So the field may be there, but you can't see it. In this particular case, this very nice MEG field is because the person still has spikes from the superior temporal plane, which produces a very nice tangential field that the MEG sees quite well. Now, perhaps the most common scenario is that the MEG sees the tangential field component, EEG sees a radial field component. The two are synchronous, so in this particular case, EEG at least adds the fact that there is radial activity. And this can be seen in this example, for example, MEG spike, EEG spikes, the simultaneous fields. The EEG sees radial activity in the lateral aspect of the temporal lobe. The MEG sees tangential activity from the temporal tip, but both are essentially telling us that this anterior temporal region is the active region for both components. So in this case, EEG adds the radial component information. Now, what goes around comes around, and there are instances where the spikes are purely radial in their field. Because of that, MEG can't see it. And obviously, in this case, EEG adds not only the orientation of the field, but also the location of the source. And here's an example. Here we have an EEG spike with essentially no MEG spike. That's because the field is very radial. Negative maximum over this side of the head, positive maximum on the other side of the head. The dipole is horizontal, definitely radial, lateral temporal lobe. So lateral temporal cortex is an area where there would be EEG spikes without MEG activity. So the bottom line is when the MEG and EEG fields are synchronous, then the characterization of the source is the synthesis of MEG's more accurate location and EEG's more complete dipole orientation information. But remember, if the fields are radial, there's likely to be no model-worthy MEG field, and EEG should be performed because it's what provides the information for you. If you didn't model the EEG, you'd essentially be throwing away this clinical information, which makes no sense. Now let's talk a little bit about timing, leading and lagging. So MEG is always going to see our tangential component. EEG in this case is seeing the radial component. But in this scenario, the MEG leads. MEG leads. So the EEG is really only going to provide us the radial component of the propagation. Here's an example. We have a nice EEG spike. It's very radial. Here's the source model. It's deep to the cortex, so probably if we project it out, we'll say that this frontal operculum cortex here is a likely source producing this orientation. That's fine, except for the fact that the MEG here is about 30 milliseconds earlier. Here's the MEG field, and here is the MEG source. It's a tangential source, and how would you interpret this? Well, obviously, the earlier activity must be coming from this inferior frontal operculum cortex, and then what's happening is probably spreading out here into the lateral convexity cortex when the EEG is seeing it. So this EEG is dipole is deep, but the cortex it's modeling is out here. So we're talking propagation from deeper in the sylvian fissure around the lateral side. Yes, this is a patient with Landau-Kleffner syndrome. But we can have it the other way around, where the EEG leads the MEG. Here is our MEG spike here, a nice MEG field, and a nice source activity here in the superior temporal sulcus, which is usually the deepest sulcus in the temporal lobe, so it's a very good source of MEG activity. The problem is the EEG spike is earlier, seen here, and if we model the EEG spike with a moving dipole, we see it moves from more basal to more inferolateral cortex before we see the MEG. So what we're probably dealing with here is actual initial activation of the base of the temporal lobe with propagation up and then into the superior temporal sulcus to define both the earlier EEG and the later MEG activity. So when the MEG and EEG fields are asynchronous, source models of the leading field define the origin. Those of the lagging field help to characterize the propagation. We really want to know where things start, not necessarily where they go. So in 4 of these 6 scenarios, EEG added something to the completeness or accuracy of the interpretation of the spike, and in 2 of the 6, EEG provided the location. So bottom line again, MEG and EEG strengths are complementary, so it makes good sense always to model EEG with MEG. I know this sounds to make great common sense, but Overlook is essentially the only MEG center in the United States that models both MEG and EEG. So what do we use this thing for? Well, the indications of MEG are pretty simple. The major one is pre-surgical epileptic focus localization. I personally feel that MEG should be part of a routine evaluation. We do MRI now, we often do PET, we often do SPECT, we often do this or that. MEG, I think, should be part of the standard evaluation. But if you want to be even more conservative, certainly MEG definitely should be part whenever intracranial EEG is considered. If you don't have enough localizing information that you have to put electrodes in the brain, then you need more localization, and MEG is a perfect way to do that. Even if you can't find enough information to go to surgery directly, at least you can more accurately place your intracranial electrodes. So every person who is a candidate for electrode implantation should have a MEG. And in my opinion, nearly everyone who's just a surgical candidate should have a MEG as part of their routine evaluation. The other thing that MEG is good for, both related to epilepsy but also related to tumor, is finding eloquent cortex. The accuracy of localization of MEG being greater than that of EEG is particularly important when you need to know where vital cortex is. Visual cortex, auditory cortex, motor sensory cortex, those can be very easily localized with MEG relative to a tumor or relative to an epileptic focus. Now you might say, oh, fMRI is the way to go for this sort of thing. But remember, if your tumor is in any way vascular, either plus vascular or minus vascular, it's going to distort your fMRI localization. MEG doesn't care about the vascularity of things. It will localize the sources of eloquent cortex activity regardless of the vascularity of the tumor. Now there are some special niches for MEG. And perhaps one of the greatest is the pre-surgical evaluation of patients with skull defects. This is most often seen in the reevaluation of patients who have seizures recurring after surgery. If you have a hole in the skull, your EEG is going to be distorted, and your localization by EEG may be inaccurate. MEG doesn't care if there's a hole in the skull. In fact, MEG doesn't care if there's a skull there, period. So it's very good to localize residual spikes in patients after surgery. It's also good that localization accuracy is important for people who have multiple lesions or a large lesion. Let's say there's a large resection site or a large area of encephalomalacia. Where around that area might the spike or seizure focus be? Makes it very good to localize which aspect of the lesion is most likely epileptogenic and where the surgeon would need to take more tissue. Same way with multiple lesions. Let's say a kitty has multiple tubers, but the seizures seem to be all of one type. Well, which one of the tubers is the bad one? They can be very good in localizing which of multiple lesions is the epileptogenic one. Finally, MEG is very good if your EEG is confusing. And I'll show you some examples of this, but confusing EEG usually means that the fields are tangential, because a lot of people are used to thinking that the source is under the negative maximum regardless, and that's only true in radial sources. Often with tangential fields, the source is between the two maxima, which may be definitely falsely localizing, but even falsely lateralizing. And finally, if your focus is near sensory motor cortex or other elephant cortex, MEG is very good for pinpointing both. This is where the good cortex is. This is where the bad cortex is. Here's an example of somebody who had a previous surgery with a major resection. Where is the residual spike focus? MEG says it's right here at this edge of the focus. EEG says, man, I don't know, because I'm out of the head, because there is a skull defect there. MEG doesn't care about the skull defect. Here's an example of a confusing EEG. We have what looks like a really nice spike here, but the problem is here in bipolar, there is no phase reversal. This is up, up, this is sort of down, down. There is some sort of like phase reversal here, but that's the wave, not the spike. If we go to common average reference, it's almost as confusing. We have a frontopolar negativity, and we have a big posterior temporal positivity. We have a tangential field that can be seen here, or actually this is the MEG doesn't care about the tangential field. It says we have a source here in the remaining temporal tip cortex following this more posterior or mid-temporal resection. Very nice localization. It doesn't care. Whereas the EEG, we have this tangential field. EEG is not as accurate, again, rather superficial because of the breach. But fields, particularly tangential fields like this, the source is not up here under the negative maxima or back here under the positive, but it is between the two. So when is MEG not a good idea? Well, certainly if you think the person has generalized epilepsy, using MEG in the hopes of finding a surgical focus is not necessarily a good idea. If you think it's secondary bilateral synchrony, and or there's always a lead on one side or another, then MEG is excellent for finding. But if the person has truly generalized epilepsy, you're not going to find a focus. Similarly, if the person truly has multifocal epilepsy, that is to say seizures and spikes coming from all over the place, you're going to find multiple foci with MEG, and then you're still going to have to ask the question, which one, if there's any single one, is the one that causes the most problem. The other issue is there are often patients who have no spikes seen on EEG with long-term monitoring, no EEG spikes. In my experience, that means there's about a 10% chance of MEG spikes being present without the EEG. Now, that is a small percentage, but sometimes it pays off big. And here's an example of when it was worth it to try the MEG. This person had a supposedly normal long-term monitoring. Here's the guy's asleep. We can see the posts back here, and we see this central vertex activity, which is probably sleep complexes. The interesting thing is when you look at the fields closely, this is a nice vertex sharp wave with a negative maxima vertex, and essentially nothing on MEG, because MEG doesn't see this radial activity. But this guy over here is not quite the same as this one. There is the negative maxima is somewhat asymmetrical. There's a positive thing here. We actually have a bit of a tangential field, and look at this beautiful MEG field that is associated with this. If we look at the MEG spike, we see here in the interhemispheric fissure. We see this nice tangential MEG source on the left side, mesial frontal cortex, and this person had a frontal supplementary motor-like seizure activity. No spikes were seen. They were there, but they were masquerading as vertex sharp wave. Only with the MEG did we pull out the fact that there was this nice mesial frontal source. So conclusions, again, the same thing. MEG and EEG strengths are complementary. MEG has superior source localization and sensitivity. EEG shows more complete characterization of source orientation and propagation. If you use both, you're going to improve your characterization of spike and seizure foci. And in my opinion, clinical epilepsy evaluation should always be done with both. And that's what we do at Overlook. And I've been trying to convince everybody else in the country to do the same thing. Slowly but surely, I think they are coming around. Now let's look at just the last few minutes. Let's look at a couple of cases to show you how this would be worthwhile. All these cases are, I think, from NEREG patients. Here's a 19-year-old guy who had MEG for part of a pre-surgical evaluation, had a partial left temporal lobectomy before, but his seizures came back. Video EEG said he had left hemispheric seizures, but we're not exactly sure whether it was temporal or not. He obviously had the post-surgical changes on the left side, and SPECT showed increased radiotracer accumulation in the left posterior temporal and right frontal foci. Okay, what are you going to do with all that? Well, let's do a MEG in this guy. And here is the EEG, his remaining EEG spikes, and sort of an oblique type orientation. But EEG here was pretty good, saying, look, we have some residual source activity in this aspect of the temporal lobe posterior to his previous resection site, but he's got a hole in his head, maybe because of the surgery. Maybe we're being fooled by a breached rhythm here. We need some confirmatory information, so let's get the MEG. So here's our MEG spike, and here's our MEG source saying, well, there may be some radial activity, but there's clearly remaining basal activity here in the temporal lobe, a little more posterior. Same sort of location behind the previous resection site, but there's basal activity as well as maybe lateral activity. But this is good. We see that residual epileptic activity is just posterior to the resection site. Whether or not he can go directly to surgery because this is left hemisphere, or whether another study would be needed, at least we would know where to put the electrodes. Here's a 13-year-old boy, has daily seizures, daily seizures on a bunch of medications. His video EEG shows right posterior slowing and frequent spikes. Are they occipital? Are they parietal? What's going on? He had some MRI changes in that region, but the PET again was anterior temporal lobe, increased activity right. I mean, it's again a confusing sort of thing. Let's try to use the MEG to sort some of this out. This guy had spikes out the wazoo. Look at all these spikes. Bang, 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 bang. Posterior O2, P8, sort of obviously the right posterior quadrant on EEG, but we need better localization than just quadrants. So let's take a look. Unfortunately, he did have a few frontal spikes on both sides, left and right, so it is a bit confusing. But here is his predominant MEG spike, beautiful MEG spikes, nice dipolar field, localizing to the mesial aspect of this occipitoparietal cortex. Very nice tangential field. The interesting thing is that his EEG spikes, if you look at the very, very first peaks of the EEG spike, it too agreed about this mesial location, but the major spike that everybody would look at out here is this radial spike with suggesting a radial or lateral occipitoparietal source. So interestingly, if you went just with his major EEG spike peaks, you would get this propagation, probably localization out here laterally when the source was mesially. So here the MEG sensitivity was very important, and here MEG led the EEG, except for some little tiny components that you probably didn't pay attention to. So this was a good example of MEG leading EEG. Another confusing EEG example, here in bipolar EEG, again, there's no phase reversals. That's the bitch. And in common average reference, we see positivity on the left side and negativity on the right side. Okay, that's great. Do we go with one? Do we go with the other? The field is, again, tangential. So you can't go with either. This source is not under the negative or the positive maxima. It's between the two, much the same as with MEG. Here's our MEG localization. It says, no problem. This is a mesial occipital on the left side. I forgot to tell you, all my 2D MRI images are anatomical, left on left, right on right, so that they match the 3D images above. Sorry, I didn't tell you that earlier, but you could tell from the 3D MRI reconstruction. EEG source model showed this basically the same thing. So this is an example of false lateralization. If you're paying attention to the negative maxima, you pick the wrong side. So analysis of the field, either EEG or MEG, is very important. A 37-year-old woman on a bunch of medications. She has some right frontal slowing and right temporal slowing as well. Question of right mesial temporal sclerosis. And here's her EEG. Again, it's a tangential field, so it's very confusing. And we're dealing here with what we call ambiguity. Are we modeling here the temporal lobe tip, or are we modeling the orbitofrontal cortex? Sometimes with EEG, you get this ambiguity, and what you need is some confirmation one way or another. In this particular case, later on in the spike, it seems to be more temporal. Earlier on in the spike, it seemed to be anterior. Let's take a look at the MEG, and the MEG here in red says, no, this is a temporal spike. This is not an orbitofrontal spike. Go with this localization. The ambiguity here was resolved by the MEG. 12-year-old boy who has right facial twitching but no interictal abnormalities, no seizures. Uh-oh. Here we're dealing with one of these no EEGs on long-term monitoring. It's a 10% chance of seeing something. But in this particular case, we did have a nice MEG spike, and the MEG spike localized to just behind the probable motor cortex here on the left hemisphere, which would go along with his right-sided findings. So we were able to find something on MEG, even though he did not have any associated EEG. Here's showing he has both MEG spikes of opposite orientation, which you can often see. And by averaging on the MEG, we were able to pull out an EEG field, modeling here with a red dipole. So sometimes, even if you can't see the EEG and spontaneous activity, if you average the EEG based on the MEG, you'll find a complementary EEG field. And I think this is the final one. A 37-year-old woman being referred had a right anterior temporal lobe resection 8 years ago, having new seizures. What's going on? And here we see a very interesting phenomenon. Positive EEG spikes are seen most commonly post-surgical resection. particularly if there's some remaining mesial tissue left, and there may be a little bit of mesial tissue left after this temporal lobectomy, which is these nice positive spikes. The MEG in this particular time said, well, there might be something going on in that residual mesial tissue, but there's definitely something going on in this frontal opercular area. A very gorgeous, very strong MEG spike that was not really seen on the EEG. So in this case, the idea would be, if you're going to study her, be sure you study both the frontal operculum as well as just taking out some residual temporal cortex. So that's it for this webinar. I hope you have enjoyed it. I hope you understand the relationship between MEG and EEG better. I hope you now know the indications for MEG, the strengths and the weaknesses of both techniques, and how using both together can provide you with a lot of useful information that is not apparent just in the visual inspection of EEG traces. Thank you for your attention. That's all for now.